Okay, good afternoon. It's February 13th. House Healthcare, and this afternoon we have Commissioner Levine in with us to go over budget recommendations for the Department of Health. And welcome.
Great to be with you all again. Mark Levine, Commissioner of Health. I'm accompanied by Megan Hoke, who is in our financial division.
Yes, business office, the financial director.
Yeah, right. And we have prepared a presentation that will spend a few moments giving you a broader view of the Department of Health and public health, knowing that there are new committee members. So if that's okay, and then we'll transition to the budget, where we will spend time on mostly the major initiatives as opposed to the ups and downs. But we are happy to fill in if you need any of those ups and downs done. But most of the things we'll talk about will be the major grant programs. Okay, so always tough when slides are behind you. Oh no, that's not
Yeah.
beautiful. Yeah, just so I know that we're on the same slide.
And I do want to remind committee members that, Department of Health, they cover many things and our committee doesn't. It's not in our purview, a lot of the programs, the wonderful programs that they have, but let's keep that in mind as we're.
Right. But in some way, they're all connected to things that you're connected to. So I always like to start with the mission statement just because it is what gets us out of bed every morning and coming to work across the entire department. And it does actually summarize nicely what we're all about. And though we're in a rather different environment from Washington right now, we are still leading in our values with the word equity. And you'll also notice the word inclusion is there. So that's important.
Thank you.
The next slide shows. This one doesn't change.
Oh, no, because it's mine.
Oh, well, I could do that. But see, that doesn't help because I don't know if that is actually, I know the order of the slides. I just don't know
No,
which
maybe
one
it
is
doesn't
actually,
help.
yeah. So,
New slide, I'll say new slide.
yeah. So this one basically says definitions public health 1.0. 1.0 is really built on the triad of fighting infectious diseases so we don't have epidemics, preventing any harm to people from environmental threats, and lastly, promoting optimal health to prevent chronic disease, which of course costs 80 cents on the dollar of what we spend in this country. So those are all very, very important. And the other important concept the slide implies is that we go from what I did for many, many decades, which is taking care of people one at a time, to thinking about the population at large. So the next slide goes to the words health equity, just to show that public health 2.0 means we look at health-related social needs, access to wealth versus poverty, housing security, food security, all those things. Public Health 3.0 is really built on the foundation of health equity, everyone having the same opportunity for good health, because we're quite aware, because we have the data, it's like Arby's, we got the meat, but we have the data that basically tells us that though we're one of the healthiest states you'll ever find, and the average Vermonter is quite healthy, when you start to really drill down in the data, you realize there are populations that don't enjoy that good health. And they're always defined by discrimination, historical injustice, bias, etc. So we're obviously talking about populations defined by race, defined by gender, defined by disability status, etc. This is called the health impact pyramid. which really shows you sort of how clinical medicine, healthcare versus public health. So top of the pyramid is means more individual effort needed to have an impact. Bottom of the pyramid means population impact. So the top three parts of this was my career for a long time. A lot of counseling, education, and indeed, that's quite frequently successful. Though the person I may have talked to on day one about tobacco cessation, it may have been 15 years later when that actually happened. Because think about how challenging lifestyle changes are. And doesn't mean that's not an important thing to do, but it doesn't have the impact that other things do, as we'll see in a second. Second rung is clinical interventions, meaning my managing the chronic diseases that couldn't be prevented, that are so frequent. And the third rung is really what we call health maintenance and prevention. So are you getting your immunizations? Are you getting screening tests for cancer, whether that be colonoscopies, mammographies, you name it, whether you're getting screened for cardiovascular disease, brief interventions and for people who are using too much alcohol and how do we work with them? That's really the top of the pyramid. The next rung is really public health, changing the context to make individuals' default decisions healthy. So what does that mean? All the things we've done in the tobacco world, making cigarettes more and more expensive because of the taxes. So eventually people go, maybe that's too much money. Making restaurants places we want to go because we know we're not going to get lung cancer when we enter the restaurant. It also has to do with we can't buy trans fats anymore in a box of crackers because we know how bad they are. The companies won't even put them in anymore because they know that people aren't going to buy them. Whole host of things like that. If you're lucky enough to be in a community that has fluoride in the water, you don't have to make a decision about the water you drink or what to do with it to keep your teeth healthy because it's already taken care of. And then the bottom rung is really the heavy lifting, really trying to change those socioeconomic determinants of health in big ways. So the biggest thing going on in the legislature, they tell me this year, is housing. Well, that's healthcare and that's health. So I think we all know that because this is the kind of committee we're sitting in right now. But the reality is it's a major public health kind of intervention to make sure somebody doesn't have to sleep God knows where and has a roof over their head. Same thing with making sure that we take care of food security. I testified yesterday about the farm to early childhood education kind of programs. And it turns out 2 out of 5 Vermonters consider themselves food insecure, which means their kids are going to be food insecure too. And so if they actually are in childcare and they get breakfast and lunch each day, that's like a major public health intervention for a big part of our population. So that's the bottom rung of the ladder. Big impacts those things have because you can imagine the state of wellness or non-wellness somebody will be in if they don't have good things like we just talked about. And I'm not going to go through this slide in great detail. It's basically, here's all the kinds of ways public health interacts with anybody in their communities and their day-to-day lives. And we always like to say, nobody knows we're around unless we have a pandemic or something because we're behind the scenes doing all these kinds of things. But those are the things that really we all do and everybody in the state, community, nation, you name it, benefits from. So here's the Department of Health. Yeah.
Wait, did you have a question?
Well, I do, and because it's about changing behavior, and you mentioned things that change behavior, and I can't help but think about soda, because it's such an integral part of development
Yes.
of diabetes and heart disease.
Yep.
Talking about, of all the array of things that change behavior, taxes seem to be having
They
the
were.
most impact.
Yes.
So I was just wondering about your thoughts about that, if you're willing, but I can totally understand if.
Oh, no.
Yeah.
Well, there's no piece of legislation, so I don't
Not
have to
yet.
come out on one side or the other today.
Yeah.
And you know, I work for a governor who is very sincere when he says no new taxes
Mhm.
while he's governor.
Mhm.
So that's fine.
Mhm.
But the reality is, if you look at the evidence, It's accumulating. It's not like slam dunk yet, but it's pretty close. There are places in this country, most of them cities and not states, where they've been able to show effectiveness of putting a tax on what we call sugary beverages. It's not all beverages, obviously. There are actually countries that also have been able to show this. So it's probably a good public health intervention that could be successful wherever it might be tried. Along the way, though, there's a difference now in what people are drinking in 2025 compared to even 5 years ago. A lot of people have given up the sugary parts of the beverages. Doesn't mean what's in there instead of the sugar is the safest thing in the world. We won't get into that, but certainly not with the calorie load and the risk for chronic diseases like diabetes. So again, that would be one of those changing the context things that actually might work if you were worried about the obesity epidemic and all the diseases with it.
Yeah, I kind of worry, if I may, about, well, I think half of our population dies of heart disease and, those kinds of related
Yes,
diseases.
it's the leading cause of death.
Yeah. So, but we're not talking about it too much. And I'm just wondering how to do that. And when we think about it from a population level,
Yeah.
it wouldn't take a whole lot of change to
Right.
have an impact. So
Right.
when you're done and if you
Yeah.
have room in your life to think about a process about that.
Oh, yeah, yeah.
That would be really interesting. I
agree.
know people think it's a regressive tax and that's a problem and I get it.
Right. But even mothers are changing their behaviors with their kids. It used to be a juice box all the time, and now even the benefit of having juice as the beverage is questionable.
Questionable.
So I think we're seeing cultural changes. It would be always nicer for cultural changes rather than imposed policy changes.
But we spend so much money, at the end of life on pharmaceuticals instead of,
Yes.
I
Right,
just
right.
not really.
Trying to interfere with that 80 cents I talked about
Yeah,
before,
yeah.
because that's really real. Good.
Thank you, I appreciate that.
So I'm going to go through each of our divisions just with examples, not going to make it a long lecture. Notice the department is built on a foundation of health equity. So starting with environmental health, the legislature helped us with the work on school drinking water. We also have other programs to prevent lead in, old houses with lead-based paints, etc. A lot of stuff going on in the climate and health world, which we've lived through in Vermont several times over now. Having said that, it's probably the biggest health challenge of the century. And we have 1.3 FTEs in our department devoted to climate change out of the 600 plus employees. The work on school air with PCBs has obviously been in the news. Some parts of the state even more than others. And the work on PFAS in some parts of the state even more than others, but very important work. This is environmental health. Moving to family and child health, that's where the focus of public health has often been for tradition. And we're talking about the progression from being pregnant and not having a child yet to when that child is born and how formative those initial months and years are. Everything can go really well or really badly and set the tone for the next several decades. Moving into adolescent and school health, moving into programs like after-school programs that try to prevent adolescents from experimenting with various substances or habits that might be not the healthiest, and all the kinds of programs we have early in life, like WIC, like home visiting programs with nurse practitioners, family specialists. And I think the next slide just shows WIC, because it is such an important thing. Its funding is still there. We're still using it. It's working. Hopefully that will not change. Laboratory science and infectious disease, everybody's aware of because of the pandemic, but there's a lot of infectious diseases besides respiratory ones. And in Vermont, especially, vector-borne disease is a very high-ranking one. This is where our immunization programs are, and you'll hear about them in a second. and our public health lab, which is quite sizable and is currently looking at the every person hospitalized with the flu. We're doing extra analyses in the public health lab to know that it's not avian flu and to know that they have not contacted avian flu. So those are the kinds of things that happen behind the scenes in our lab all the time. Yeah.
I have a question that I wanted to ask you the other day was from a constituent, wondering if with the flu in general, flu A and B and the uptick now, and the causing closings of schools in some cases.
Yeah.
Do you know if anyone is keeping track of the burden on kids and schools in particular of current uptick in flu? Is there a way to capture that?
Only knowing when and how many schools have had to close for how many days, that kind of thing. Because it obviously goes beyond schools, it goes to workplaces, it goes, to society in general, community events, you name it. But schools is probably the easiest one to measure.
Yeah.
And when it happens to like in a long-term care facility, it generally doesn't bring down the whole facility like the way we worried about with COVID, but it can actually still do a lot of damage.
Thank you.
Local health, just to point out, we are a centralized health department, so we have 12 district offices all throughout the state. They're not their own local health departments. They're basically aligned with what's going on in the central office here in Waterbury. And they're the boots on the ground. They have the best community partner relationships because they're very local. And they also can provide things like vaccine clinics. They all provide WIC to the population that's germane to their region of the state, et cetera. So a really, really critical part of our infrastructure. This is the health promotion disease prevention, which is essentially stuff we've talked about already. But key parts of that program have to do with the tobacco program, which is all preventive, a little bit of treatment, and the oral health initiatives, which are really going well, actually, in Vermont, though we have such needs in terms of personnel. But still, there's a lot of very innovative and progressive stuff going on. And then I mentioned maternal child health before and the focus on that end of life, but one of the things I'm semi-proud of in my term here is to try to also extend it to the aging part, especially with the demography of Vermont. And you probably saw Age Strong Vermont and our efforts with Dale. We're both co-sponsoring that. And I hope that in future years, you see commissioners in this seat who are then advocating for new budgetary changes to get through some of the Age Strong Vermont proposals, because there's a whole compendium of them. But we have to start slow and work our way there. And this was not the year to make Age Strong Vermont like where the budget's going, because you know where the budget's going. So emergency preparedness and injury prevention, again, pandemic, you saw that. Every time we've had a flood, you may not see that, but we're a major part of that response. But the injury prevention part I want to emphasize as well, because that's talking suicide prevention, we're talking falls prevention in the elderly, prevention of anything that you think is bad. Generally, we try to be involved in, so car seat programs, firearm injury, all of this stuff, again, wrapped up in about 1.3 FTEs, because we get our money from CDC, and this is what we get funded for. And our EMS program is in that division. A nice flood picture on a day that we're having snow. And then last but not least, I said we got the data. So we have a very robust statistics and informatics section, which to the citizen, they see it in our registries and our vital records. But to legislators and anyone who cares, we have tons of data that we put data briefs out on. We have survey data. It's all on our website. So when people really want to know about a public health problem, we probably have something to say about it based on data, because we try to be data driven. And then Last but not least, the substance use programs, many of them prevention, but all through the continuum of prevention, intervention, treatment, and recovery. The prescription opioid awareness program and the prescriber system that's really brought down the pathway from prescription misuse to heroin, let's say, has been in our department. That's that. Now, I know your committee doesn't really interface with substance use. The one major new budgetary ask we have this year is in that arena. So if you want to hear about that, I should introduce it with just telling you what our division is like.
Why don't you introduce it? We're really familiar with this slide because our
Good.
Department of Mental Health uses almost the same thing.
Yes.
So yeah, absolutely. Just give us a.
Just
brief
take 2 seconds.
introduction.
Yeah, we'll start at the bottom. Bottom is prevention. So legislature and the governor got together a few years ago and we get $3 million a year. As you'll hear now, that's going to be higher because of the cannabis success in our state. It's funding what we call prevention lead organizations in each region of the state, prevention coalitions in all communities. It's allowing us to really scale up the prevention work at the community level, matched by prevention work at the school level itself. So it's a lot of stuff buried on the bottom part of this slide, which ends up, it's too much to give you at one gulp here. Moving to the next layer, recovery supports. So that's the other end of the spectrum, someone who's had a substance use problem, gotten treatment and is now trying to get their life back together. And recovery services are really critical to that. So they comprise recovery centers everywhere in the state with peer counseling in those centers and lots of support services. And it also involves the entity, which you'll see in some of your bills, of recovery housing. So people, sometimes they call it sober housing, whatever, but it's basically a place where people can get their feet back under them while having a roof over them and trying to, get some of the work-life skills that they need and job again and all that kind of stuff. So very, very important component. The next level up, intervention and harm reduction. Harm reduction is basically Narcan on the streets, fentanyl test strips, drug testing machines, syringe service programs, needle exchanges as they've been called, and most recently now, if it ever opens, then Overdose Prevention Center in Burlington, which is slated to open. I mean, they have to do all the work to site it and get a provider to run it. But from the health department standpoint, we put out our guidelines and what we expect to be followed. And it's up to Burlington now to start the ball rolling. So I know they're anxious to do that. So I'm not criticizing them. It's just these things are not overnight. Imagine if you said, well, I want to have a overdose prevention center like on State Street. And what would the citizens of Montpelier say? Well, they might say, great, perfect place to have it. But there probably would be some discussion. And so that's the kind of thing they have to get through. Plus, who would run it?
Can I ask you about the PIP beds?
Yes, the PIP beds are important.
Yes, and I ask only because I have a constituent that
Yeah.
asks me about them all the time. Is
Yeah.
the emergency room physician.
Yes.
And I know that some of them were closed down.
Yeah.
And I'm wondering if those have been reopened.
So PIP beds are public inebriate beds, and they're basically meant if somebody's like drunk and they need a place to be safe, where others can be safe and they can be safe, and sort of get through that episode. If they're deemed to be clinically stable by somebody in the emergency room, usually, they can go to one of these beds. If they're not so compliant or they're aggressive or just not going to be safe, the only place for them to go is our Department of Corrections. Again, not forever, just for like a night. So the PIP beds are really an important part of that system. The problem is they were hardly used. So they couldn't maintain 24/7 staffing and have, like a bed there guaranteed all the time. So a lot of them started to ratchet down. So the proposal that we're doing now, which actually doesn't require budget money because we have other monies going to this, is reopening some of those that have closed, expanding to some other regions that didn't have any, and making sure that we use them sort of in alliance, I guess would be the word, with some of the mental health crisis beds. So there's already staff there for that purpose. So this would be a dual purpose. And then it wouldn't eliminate the staffing concerns, but it certainly would make them a lot less. So that's what is happening with that. And that's an important part of entry into a treatment system too. Doesn't always happen then, but it needs to be available.
Thank you.
Next rung is our hub and spoke section. Everybody's heard of that system in Vermont. Very successful outpatient system. Hubs are very specialized facilities for the complex patients, often on methadone, who require sometimes daily visits to get their dose. Spokes are primary care offices predominantly, where you can get buprenorphine often on a monthly basis because you have a lower level of complexity in your care. And major innovator program is getting buprenorphine pretty much on demand. Go to emergency room and you say you want it. You can get started right there and then connected with a treatment provider. Many of our EMS are now gaining the competency to be able to administer that first dose as well. And then the top level is the so-called residential treatment system, which is an inpatient system. And on the next slide, you'll see that we have abundant people currently in outpatient treatment because most people don't need inpatient, but there's a smaller number in the residential bar graph that is still an important component of our system. And you'll hear when I close the whole session on the policy proposal, what we're proposing for that part of the continuum. So that's a quick run through. And now we will do the same with our budget.
I think Daisy has.
After this question.
Yes.
I just want to make a quick comment about how exciting it is to see that you are using a modified version of the pyramid that DMH uses because of
Clarity, yes.
and it's a hint at integration.
Yes, I'm all for
You're
integration.
using the same symbols and
Yes,
everything. So thank you
Absolutely.
for that, sending that message. It's
I
good.
will send that message back to my team too. Because this is very good.
Yeah.
Really illustrates well. Picture is worth 1,000
She invented
words.
it.
I didn't invent it, but I trust the symbol.
Let's just say she was integral
Yeah,
to.
I know, she
We
has
want to celebrate you.
some connection in life to mental health. And as you know, being part of the Mental Health Integration Council, I was very, very motivated to make sure we integrate as much as possible. So do we have we are now at what our budget looks like. So we started out with 8 years ago when I began my job, the budget was about 150 million for the department. And I'm not taking credit for the fact that it grew like this. I'm just saying this is what's happened over time. Obviously, with the pandemic, we got abundant money, most of which is now disappeared or disappearing because we're out of the pandemic, they tell me. I want you to be impressed by the yellow on the pie chart because that's federal funds. So we are very, very much funded by the federal government, mostly CDC, but a variety of parts of the government for that 40%. And then if you take the turquoise or blue color global commitment, that represents even more federal money. So when you look at the dark blue, narrow slice of the pie, that's general fund. So it's still critical, but it's certainly dwarfed by these other major categories. And then we have special funds, one of which you're going to hear about in a second, like immunizations that are self-evident. So we have 3 appropriations, administration and support, which we'll say almost nothing about today because it's not pertinent in terms of newer things, public health and substance use. And this budget that we're proposing, or the governor is proposing, is $11.2 million higher than the previous fiscal year, which is a 5.2% increase. But it does provide full funding for our current service budget and does have $6.5 million of new activities. So the punchline slide here, and you can have your.
Thank you.
Thank you. Is that fully funded, as I said. The cannabis tax has been kind to us, as you'll see, and there's some new funding that we need to talk about. So here we have in the administration and support, what I call, and Megan will correct me if I'm wrong, a bookkeeping change. Because originally the Office of Health Equity was supposed to go into the Agency of Administration. And it's been decided that that office is going into the Department of Health. So this is just a change in where the funding stream. And there are several positions associated with it. There's a director position and a support position.
What do you want to?
I'll let Leslie go because she probably is going to have to say.
I'm gonna ask the same question. What's the theory behind this change?
Because it's called the Office of Health Equity.
But it doesn't change its work.
Absolutely. Well, it shouldn't. No.
So that would be the
No. And
question.
it's still very aligned with the Office of Racial Equity and all of that.
That's interesting. Now they're split. I mean,
Yeah, but it wasn't like our decision, but it also, unlike what's going on with Ukraine and Russia, the Office of Racial Equity and the leaders of the Health Equity Advisory Commission, this was all a consensus process to make this happen. So it wasn't like it just happened.
Got to it.
All right. We know each other well enough in this committee now that it's nice.
That's weird.
All right, so now we're going to the public health budget, which is our largest, 58% of our total budget. And just about every program that's public health in our department, other than the substance use programs, is in this appropriation. So the only substantive changes are in the grant section. And the first one, as promised, is in the immunization program, which is pretty much almost all of the costs of that program. Now, we have what's called a state vaccine purchasing program, and the cost increases that are reflected in this table are related to that program. So we are a universal vaccine state. We have a Vermont vaccine purchasing program, buys the vaccines from the CDC. It's a federal contract. Supplies them to all the providers in the state at no charge. And that's whether you're a child or whether you're an adult, as long as you're an adult under age 65. Because Medicare is not yet in that, but we have hopes that that's going to happen soon. But that's just the way it's been forever and ever. And the way the program is funded is through assessments to the insurers who cover Vermont lives, which are deposited in a special fund. And the insurers make out pretty well, actually, because number one, we're getting a significantly discounted price when we purchase them this way. And the people who are actually getting vaccinated aren't going to get some of the downstream medical costs if they've gotten vaccinated that they might otherwise get from not having taken that opportunity. You have a question?
I do, and I might be digressing a little bit, but I've been thinking about immunizations because we've heard, and I think you alluded to this the other day, that our influenza vaccination rate is down. I think I recall you saying we're one of the best states and we are not to be proud of that.
Right.
So, I mean, I've been thinking about it in context of you know, people not getting the COVID vaccination, which is leading them to not getting
Yeah,
immunized or not getting the influenza vaccine. And I'm wondering if we're seeing that on the level, particularly with childhood vaccines,
No.
that we're like having a backlash.
so our rate of the K through 12 getting into school with the vaccines you're supposed to have is 94%, which is really good. I think it is
Is that
95.
stable?
It's been pretty stable. Many states and many countries, including our country, things went down because of the pandemic and the post-pandemic sort of response to everything. We've kind of held in there.
Okay.
Having said that, though, yes, we're concerned because you can get exemptions to getting your kid vaccinated. And you have to be very careful. We used to have this philosophical exemption, which is not an issue anymore, but there are still opportunities to get medical exemptions that aren't potentially justified, but you get someone to sign off on it and you got a medical exemption. So we watch that very closely, but it hasn't gotten out of hand at this point. Even though we don't like to see it, it has not gotten out of hand. So I think we can be assured that for our kids in school, the rate's hanging in there and we're not gonna suffer because of that. It's much more in the adult world when you have a voluntary opportunity to go get your flu shot or your COVID shot, your shingles shot, what have you. But you know, we see some promising things too, though, like the RSV vaccine for adults, 75 or older or younger than that with other diseases. The uptake this year is over 30%, and this vaccine just came out like a year ago.
Wow.
So I consider that good news because, you know, I'm not of the age where I could get it yet, but at the same time, I'd probably think about it and say, balance the benefits risks and wonder if I really needed to get it this year or not. So to have that kind of a response is pretty good. And new mothers, while they're pregnant or when their kid is born, for the first 8 months can get the RSV monoclonal antibody. And we're seeing tons of people getting that. So, and now the neonatal and the pediatric ICUs don't have all those kids in there on ventilators with RSV. And it's been career changing for intensivists and pediatricians.
That's great. That's
So there's good news and bad.
Is there, to get a medical exemption?
Yeah.
Does that have to be a physician, nurse practitioner?
Some healthcare provider has to
Okay.
sign it,
We haven't like expanded what.
No.
healthcare provi- Okay.
but still.
It's. I'm sorry, what do you,
Sorry.
no, I didn't mean to derail us, because I know we're talking about budget today, but.
Yeah, no, but this is important.
Regarding immunizations, I've got a different question. It regards around testing of women who are pregnant, of their babies before they are born.
Yeah.
How much of that do we do here in Vermont? Preventive testing of babies and
Yeah.
for certain,
I
for
think-
certain things that we can perhaps.
Yeah, so there are things like
Yeah.
syphilis that
Yeah.
gets tested for, because you hate to have a congenital case of syphilis. And I know we do that, but I put that on our particular list of what we need to get back to with you, because I don't have a statistic to give you.
Just curious
Yeah,
how much testing we actually do in helping
yeah.
pregnant mothers.
No, this is a really good question. And I can tell you we're on that and we do, I think, a pretty good job, but I don't want to give you a low ball or high ball number that's incorrect. So
And is there funding for it?
some of it, yeah, like some of our HIV prevention money.
Yes.
We can do testing for HIV, hepatitis, syphilis in pregnant people.
Okay.
So the bottom line on this is a $1.8 million increase in special fund spending authority. That's mainly because There have been new vaccines added to the numbers that we give, some of them pretty expensive, like shingles, and recently COVID. And there's also price changes and changes in the number of covered lives. So we're also requesting an increase of $770,000 in global commitment funding. For adults on Medicaid, the program is paying a per member per month assessment based on covered lives. So that cost is included in our department's budget. So that's the vaccine program, in a nutshell. Just needs a little more money because things are more expensive and we're doing more. Next item in the grants major object is the Advanced Directive Registry. So we actually have responsibility for that, to maintain that registry. We use the Vermont Ethics Network as a grantee, and they contract with the American Living Will Registry, which is a registry provider, to get customer service and administrative support. And there's an increase in there of $435,000. Sorry, not an increase, an increase of $210,000 to bring the program total to $435,000, related to less support from that Living Will registry in terms of fees and customer support. So the Vermont Ethics Network has had to pick up the slack and commit more staff time to that. But the registry is still alive. You probably get letters every year like I do. And do nothing and say, okay, fine. The final line is a special fund reduction, and that's related to the opioid abatement special fund, $1,050,000. This is grants to support syringe service programs. And this all has to do with the statutory authority of the special fund and the recommendations I need to make as Commissioner of Health to the appropriations chairs and the governor regarding this. Last year, the final budget bill had included in it a line item for the syringe service programs, and the legislation is written in such a way that it basically states, so long as the fund can continue to provide this money, it should happen on an annual basis. So we are taking that out of the line item here in our budget because the legislature and governor have agreed that this year the recommendations for what happens for this special fund will become a separate bill, considered initially by the committees of jurisdiction and then referred to the Appropriations Committee. So it'll all come out in the end, but it doesn't need to appear in our budget right now. In fact, we don't want it to double count. Hope that's clear. And then finally, the substance abuse appropriation, which I know you're interested in, but it's of less interest.
Well, we can't do anything with it.
You can't do anything with it, but you want to.
Always very.
Always interesting, I know. So we're going to get to the grants here as well. And the first line item is a change in the amount and source of funds for substance misuse prevention programming that the cannabis excise tax funds. So the governor's budget recommends replacing our current $3 million general fund appropriation with a $6.75 million new substance misuse prevention special fund item. And there's executive budget language in section 312.4 that shows the statutory changes that are required to establish the new fund. And that fund receives 30% of cannabis excise tax proceeds annually, up to a maximum of $10 million. So as you can see on the line item, it's doing well at this point in time. We won't go into our opinion of that. Just the fact is it's doing well. So there is more money to fund all those activities I talked about in terms of community coalitions and prevention work, school-based prevention programs, and such. So it's good news for public health in that regard. and it doesn't really matter if it comes from the general fund or a special fund. This will now change the way it flows into this new special fund. And this really will help us doing that scalability part of things, because so often what happens with prevention programs is if you happen to live in a community that has a coalition and has been funded well, life is good. If you're one that hasn't yet got there, you're waiting. This will really even the playing field across everybody in the state.
I think Daisy had a question.
Yeah.
So are you saying that the special fund is just for the cannabis revenue?
Yes.
And
So
why did we decide to stand up a special fund for that? I'm just curious.
well, I think originally it was so novel that it came from general funds. You won't find a lot of states kicking $3 million a year into substance misuse prevention. So we had it as a line item from the general fund, and I think, just differentiate it now. It's all coming from the originally intended source, which is cannabis excise tax revenue. I'm in the position of trying to explain something that was decided by the legislature to you, which is a hard position for me to be in.
Is everybody else for the cannabis council?
Yes, true. Long ago. Okay, so as noted in the public health appropriation, you'll see the removal of $1.2 million of the opioid abatement special fund that we just talked about. That fund, this one is for recovery housing. And again, the recommendation is going to be to continue funding at the same level as previous year. So it'll end up in that other bill that comes out later on. And then there's again, AHS net neutral transfer of $594,000 of global commitment funding from public health to mental health. And that's really supporting the work that's being done in the pilot projects on the certified community-based integrated health centers, which we're fully in favor of. And then the last thing is our newest proposal. If I could move to, unless there are questions on this.
I say we move to the next.
Okay. So I've shown you that there's a continuum from prevention, intervention, treatment, recovery. And without appearing to not be modest, I mean, Vermont is knocking the ball out of the park traditionally in what we do in the substance use arena, even though it may not appear that way when we see the problems we have in our state and the concerns people have in their communities about substance use. But there's very little in terms of programming that we do not have in our state. And in fact, there's plenty of things we do have that other states are way behind, whether it be in the harm reduction arena or treatment arena. We've done a really good analysis of things. And one place I think people agree, and that's why it's in the governor's public safety bucket of his proposals, is in the public safety sector, people who are in the justice involved community and community members, judges, you name it, see people keep recycling and bouncing back and having relapses and hearing where they used to appear and not really having all the supports they need to really make a new life for themselves. So we've looked at where some of those gaps are. Our residential treatment system has access, has people in it, does a very good job. There's been a sentiment from some that they feel they're not getting the proper amount of time in there or not able to sort of step down from more intensive levels of withdrawal management care to lower levels of more individual and group counseling and things of that sort. So there's opportunity for a culture change in how people are managed in that setting. And as you probably are aware, many people who are in the justice involved arena are going to residential treatment as opposed to just to their primary care doctor in a spoke, let's say. substance use is a chronic disease, so it's not unusual for people to have a relapse, just like smoking is a chronic disease. It takes people 6 times to quit smoking on average. So one of the proposals is on the first line, re-engagement beds, which we often call stabilization beds. Somebody may have been already in a recovery house and then they've relapsed, and that's deemed to be not safe for the people who are in there with them who are trying to do well. And where do those people go? So we want to have a safe place for them to be caught and then move them back through the system. There's also people who actually have done well in residential, but they don't have a bed yet to go to. And we want to make sure there's a place for them to be able to stay until their recovery bed and a recovery housing is open. The other section besides that, those gaps that I just pointed out, is transitions in care. And if you've done anything in healthcare, you know that that's the danger point always, is people falling through a crack because the transition didn't work well. So we're proposing some navigator positions. These are not state funded. These will be granted to the residential facilities where navigators can actually help people with all of that stuff that's needed to ensure a smooth transition to the next point in their recovery. And then finally, recovery itself. It's great to have recovery housing, but that really needs to be accompanied by life skill building, employment supports, all the kind of supports people who are going to, who have complex lives are going to need to really bounce back and make it in a long, chronic way, not just in a few weeks after they left their treatment facility. So a recovery campus model. And we've already had an RFI process that has been very successful that will turn into an RFP process once this budget is approved. That's sort of the new, what we call continuum of care, shoring up the gaps and the transitions in care issues. And that's the end of our budget presentation. With a minute to spare.
Thank you, Woody.
Yes, at the very beginning of your slides, you talked about environment.
Yes.
Probably expected this from me, regarding PFAS
Yeah,
and CB.
Yeah.
I don't know whether your budget covers these things, keeping PFAS out of our water systems.
Yeah.
And the PCBs in our school systems and testing and all that. You've been through it this past
Yes.
summer, and
I still have my T-shirt.
yes, it wasn't pleasant, I'm sure, you know. But
it turned out to be. It was
but we're still dealing.
I know that. I know
And
that.
I just.
So I can tell you that most of the money that's in the budget is in ANR's budget, not in the Department of Health's budget. But we are a critical piece of this. And there is, in the governor's proposed budget, money directed towards ANR to make sure that the schools that have already been through the testing and may have remaining remediation work to do or mitigation work to do, to make sure that that funds that work. The previous legislative year, already a pause was put on the diagnostic part through 2027. So we anticipate we're on a slower timeline on that now. So though that will be disrupted, that's not going to be the end of the game, because we do want equity. We want to make sure schools that haven't had the chance have the chance. We're hoping that we actually went through the schools that had the highest risk, but we know that it's a challenging risk assessment. So we can't be 100% right that there won't be a school that hasn't been tested that it is higher risk. But we think we got through the worst of it.
A couple of issues here. What is the threshold of PCB contamination for humans? We don't really know that. There's different levels and
Yes.
for all these things. We don't seem to be any closer to coming up with that.
Well, prior to the election, I might have said something different, but now that EPA is on life support, I don't know. But the reality is EPA, prior to all this, was moving in our direction. Because we had the more modern data and modern science, and they were like all over that, like, yes. But turning the federal ship was a lot harder than the state ship. So we could do what we could do. We think we're close to what those risk levels are, to be honest,
State,
for the state levels.
which are a lot. I can't remember.
They're a little higher than the
Yes.
EPA's, yes. But they have some opportunity for flexibility, which is why we do such good work in North Country, because we have what's called the school action level versus the immediate action level. And the goal is to be able to work with schools to make sure they actually could comply with what they needed to do and keep open while they were doing that.
And I guess my other question is, we're just discussing the school.
Yes,
We could be discussing
anywhere,
other buildings as well, our hospitals,
yes.
just our homes, everything.
Yeah, and that is a societal issue, no question. Because there are people who will work in places that they're there as long as a school employee is in a school or a student is in a school. But again, it all depends on the years of construction of the building and if those were years where PCBs were in the building materials.
Thank you.
But yeah,
Thank you for your work on that, Leslie.
thank you.
Yeah, I'm gonna parallel Woody again, Bellas Falls Union High School. We just got a bill for $3 million. I know there's only $10 million, I think, in the A and
the
R budget
Yeah,
for that. How does it get distributed? Where,
Yeah.
how are we gonna do it? They just turned off the filters. I don't know if you've ever been in Bellas Falls, but it was bad.
I've not been to that school.
It's an open plan school, so the filters were just reverberating in the entire school.
Noisy,
Horrible.
yeah.
Um,
But
so,
they have other, yeah.
yeah, so my concern, well, there was even discussion of breaking, taking the school down, but
Right.
I just wanted to understand
Mhm.
about the 3 million and how,
Yeah,
Who gets
that,
that?
that you'll have to
That's
request
A&R?
testimony from A&R/DEC, that section of it.
okay, thank you.
Okay, any other questions?
I have a question.
One more.
You mentioned a couple of times in the last presentation that we did about Bridges to Health, and you're talking about immunizations. I kind of know the backside of this where, but not for Bridges to Health, a lot of kids that are going into the school system would never have been immunized.
Yeah, yeah.
With the IVID program, which is amazing. I just want to say, are they under your purview, the Bridges?
I think they're under our purview, but they're a close partner.
Okay, because I understand that their grant has not been renewed at this point. Is that true? Do you know?
I'm not sure.
I can speak to that.
Oh,
That'd
good.
be great.
We have a current grant agreement with Bridges to Health. It runs through end of August 2026. So it has been executed and it's there available.
Okay, but after August of 2026?
The current, it's with money, the current agreement is with the budget year 25 one-time funding, and that continues through 2026.
Okay.
Yeah.
Thank you.
I have a teaching thing I have to.
Okay.
Thank
Thank
you.
you.
Very
Thank you
much.
so much.
In a quiet room somewhere in this building. Been great seeing you all again.
Thank you. Thank you very much.
We will miss you.
I hesitate to say this, but I think maybe if we get up, walk around for 5 minutes, and then we'll come back in and we'll pick up on vital. You're out of here.
Not just kidding.
I was gonna say.
I was thinking that.
Put a rope around
Probably got out of here.
it. 5 minutes.
5 minutes?
5 minutes. We're still on the air.